Hello, everyone, and welcome to this webinar organized by the Canadian Association on Gerontology. My name is Laurie Weeks, and I'm a professor in the School of Nursing at Dalhousie University. And I'm also the vice president of the Canadian Association on Gerontology. And one of my tasks is to help to facilitate these webinars. And with the excellent support, of course, of our executive director, Anthony Lombardo. We have the information about our next conference on the screen for you. So we're meeting in Regina, hopefully face-to-face, in October of this year. And the abstracts are, the call for abstracts is open, and the deadline for submitting abstracts for the conference is April 15th. So please plan to attend the conference and submit an abstract for the conference as well. So today we're very pleased to welcome Dr. Paul Stolee to our webinar series, and he is the 2021 recipient of the Canadian Association on Gerontology Distinguished Member Award. Dr. Stolee is a professor in the School of Public Health Sciences at the University of Waterloo. His research focuses on health system challenges affecting older persons, primary care, and engagement of patients and caregivers in healthcare decision-making. At Waterloo, he leads the Geriatric Health Systems Research Group and is the director of the University of Waterloo Network for Aging Research. Thank you very much for joining us today, Dr. Stolee, and welcome. And for those of you who have any questions or comments, you're more than welcome to include them in the chat room throughout the session. And at the end, we'll have some discussion. So thank you very much for joining us today.
Well, thank you very much, Laurie, for that introduction, and thanks to CAG for the invitation. I'm going to try to share my screen now. Hopefully what you see is a slide and not my speaker notes.
Yeah, that looks great. The format looks great.
Okay. Well, thanks again for the invitation. My title is Healthcare Systems for Older People in Canada, Myths and Realities. Couple things before we begin. My pronouns are he and him, and happy St. Patrick's Day. Before we begin, I would like to acknowledge that I am speaking from the University of Waterloo, which is on the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee peoples. Our main campus is situated on the Haldimand Tract, the land granted to the Six Nations that includes 6 miles on each side of the Grand River. I'd like to acknowledge the support I received from the University of Waterloo, my collaborators in the Geriatric Health Systems Research Group, and our partnership of older adults, SHARP. Some of the research I present in this webinar has received funding support from CIHR, the Canadian Frailty Network, and the Age Well Network. So I'm grateful to those organizations. I think I could have called this talk sort of rants, ravings, and personal biases, but I didn't think that would sound very scholarly. So instead, I'm going to use this outline as a bit of a structure. First, I'm going to take a brief look back. Then I'm going to talk about a few of what I'm going to call myths, that healthcare is shifting to the community to support aging in place, that we have an integrated patient-centered care system, and that health information technology is the future. And then I'm going to try to end up on a bit of a positive note. For this talk, my definition of myth is close to this one from the Encyclopedia Britannica, which says myth is a symbolic narrative, usually of unknown origin, at least partly traditional, that ostensibly relates actual events and that is associated with religious belief. So we can think of myth as something we'd like to be true, but isn't exactly, but nonetheless may serve as a guide for our efforts. Now, the theme for last year's CAG 2021 was looking back for a vision forward. So I'm going to use that as permission for me to take a bit of a brief look back. So my career in geriatrics started in the Paris of the Prairies, Saskatoon, where I was invited to work on the Saskatchewan Health Status Survey of the Elderly. This was 40 years ago, 1981 and 82. This is what we looked like. In the foreground, you have the nurses, student nurses, physiotherapy students, medical students who did the hundreds of interviews in older persons' homes, in long-term care residences throughout the province. In the back, on the right, the grumpy looking guy is me. Please note that at that point in my life, I had hair. The hairy guy on the left with the red shirt, some of you may recognize as Ken Rockwood, who went on to become a leading geriatrician in Canada and recent recipient of the prestigious Ryman Award. And in the middle at the back, you can see the legendary Canadian geriatrician, Dr. Duncan Robertson, who inspired Ken and me and many others to pursue careers focused on older persons. So what were we trying to do? We were trying to estimate the prevalence of dementia. We were trying to understand frailty. And we were trying to identify health and support needs to inform health service planning. So back to this looking back for a vision forward idea. The proportion of persons aged 65 and older in Saskatchewan in 1981 was similar to the proportion of persons aged 65 and older that was projected for all of Canada in 2001. So studying the population of Saskatchewan at that time was a bit of a window into the future for the rest of the country. A couple noteworthy findings from that work. Prevalence of cognitive impairment in persons 65 and older, 7.8%, which was close to the estimate later derived from the Canadian Study of Health and Aging in 1991 and 92. Somewhat to our surprise, we found that the number of persons living with dementia in the community was as great as the number cared for in long-term care facilities. And that finding was borne out again by the Canadian Study of Health and Aging. We also found that only a bit over 12% of persons living with dementia were actually receiving support from home care. So with that, I'll go back to the future. Now, my future took me to the University of Waterloo, where I have the good fortune to work with the Geriatric Health Systems research group. Here is a picture of us, happy and carefree before the pandemic. And here we are during the pandemic. Still happy, I think, but maybe not so carefree. The first myth, as I said, was that care is shifting to the community to support aging in place. I've often heard this working in healthcare over the years. You know, we're seeing a major shift from care out of institutions, out of hospitals, into the community to support people in their own homes. Here's a 2004 report from Health Canada saying that policy development and systemic restructuring have shifted the primary locus of healthcare from the hospital and other institutionalized settings to the home. Here, a report from the Canadian Healthcare Association in 2009 talks about home care moving from the margin to the mainstream. And more recently, here's a headline from the Hamilton Spectator in 2020 saying community care could be the big winner in the massive overhaul of the healthcare system. To that, I'm tempted to say, spoiler alert. Now, I had a hard time figuring out who this was in the picture, as the caption didn't say. I finally determined that it was the president of the Ontario Hospital Association. So read into that whatever you like, I guess. Let's look at the distribution of health expenditures in Canada. Here are data from 1975, so over 50 years ago. You'll see that there are major expenditures for hospital services and physician care, but if you look for home care expenditures, you can't find it. did I say 50? About 47 years ago. Home care wasn't big enough to have its own category. So here it is lumped in as other. So now let's go ahead to some more recent data. Here we have a similar pie chart for 2019, and we still don't see a category for home and community care. Home care is still lumped in as other spending, part of what is now a bigger piece of the pie, but still not big enough to get its own piece. Now, I didn't intend this to be a talk about COVID-19, but in a talk about older adults, it's hard to ignore these days. So we're all aware of the disastrous impact that the pandemic had on persons living in long-term care and on those working there. Here is the widely cited figure that Canada had the highest proportion of COVID deaths occurring in long-term care. We should note that long-term care was not the only sector affected. There were reports that 40% of referrals to home care could not be filled because of staff shortages. Early in the pandemic, Canadian geriatrician Samir Sinha courted some controversy by saying, if my mom was in long-term care, I would pull her out now. Now, this was a controversial position, but certainly understandable under the circumstances. But so I want to look at how have Canadian policymakers responded to the pandemic? And did they keep in mind that point of Samir Sinha's that we should be supporting our older adults at home? Most provinces promised major expenditures for long-term care and long-term care beds. Here is BC Premier Horgan pledging $1.4 billion to long-term care. Alberta is investing $3.2 billion for continuing care, though I should note that some of these funds were pledged for community care. Saskatchewan developing more long-term care beds. New Brunswick, Nova Scotia with funding for an additional 100 new long-term care beds on top of 2,500 already promised by 2024. And here is a new story about Ontario Premier Doug Ford's promise to invest $1.75 billion to fix a broken long-term care system over the next 5 years, mostly after the next election. In this slide, we see that the Ontario government is planning to build or upgrade a total of 38,000 long-term care beds by 2028. Now, there are currently 40,000 persons on the wait list for long-term care in Ontario, which to me makes this sound like the Red Queen's race in Alice Through the Looking Glass, where it takes all the running you can do to keep in the same place. Dr. Sinha and Andre Picard would have taken their mothers out of long-term care, but the wish of most older adults is to avoid long-term care in the first place. Here is a quote from a recent qualitative study by Dr. Heather Campbell-Enns and her colleagues, in which they talked to nursing home residents with lower care requirements to explore the reasons they were living in long-term care, which Campbell-Enns and her colleagues found was a strategy of last resort for families. Also here we see results of a survey done by the National Institute of Aging, which found that 85% of Canadians surveyed and 96% of Canadians aged 65 years and older reported that as they get older, they will do everything they can to avoid moving into a long-term care home. So why aren't more older adults remaining in their own homes, or as Dr. Sinha suggested, leaving long-term care to go back to their own homes? That's a more complex question than we can resolve today, but I'd like to provide two case examples that I think give some additional detail on this. About 10 years ago, our group undertook a systematic review of studies that compared home-based rehab for persons with musculoskeletal disorders, with rehab provided on an inpatient basis. Our review found that older adults who received rehabilitation in the home had equal or higher gains than the inpatient group in function, cognition, and quality of life, and they had higher satisfaction. So after this, we thought that there was pretty good evidence that rehab could be done effectively in the home. A few years later, our group went a bit further. We wanted to look directly at the rehabilitation care, physiotherapy, and occupational therapy provided to Ontario home care clients with musculoskeletal disorders. So we published the results in this paper in the Archives of Physical Medicine and Rehabilitation. Our study involved an analysis of inter-eye home care data using a multi-state Markov model, which is displayed in the figure here. The total sample was nearly 100,000 long-stay home care clients who had had at least 2 assessments so that we could look at follow-up data. Our analysis looked at the effect of PT or OT after adjusting for age, sex, baseline activity of daily living score, falls history, cognitive function, depression, and other measures of complexity and comorbidity. The 3 states in the center row of the figure describe home care clients who are independent in both activities of daily living and instrumental activities of daily living, state 1, who are independent in ADL but not IADL, state 2, and who are dependent in both ADL and IADL, state 3. In this figure, the bolded arrows indicate statistically significant relationships. The bottom line is that those home care clients with MSK disorders who received PT or OT services were more likely to have improved function, more likely to be discharged from home care with successful completion of their care plan, that's state 4, and less likely to be discharged to hospital or long-term care, state 5, or to die, state 6. This paper got, I think, more than the usual amount of attention that I'm used to with our papers. It made the local paper. It was in the Kitchener Waterloo Record. Big deal. And we presented these findings to home care associations and to policymakers. So we thought this was fairly well circulated at the time. So on the basis of the results of our systematic review and this statistical analysis, one would think that many home care clients would be getting PT and OT services. One would be wrong. Now, it's rather hard to find this type of data. For me, it was at least, but here we have data from a 2012 report showing types of services for 5 jurisdictions in Canada. In each of these 5 clusters of bars, the 2 bars on the right-hand side show the percentage of home care clients receiving PT or OT services. In every case, PT and OT services are the services with the lowest frequency, except for social work, and that might be a story for another day. I also found data for 2015-16 in Ontario that found that physiotherapy and occupational therapy accounted for less than 4% of home care visits. So given that the evidence suggests that even a modest investment in home-based rehab can yield substantial gains in terms of improved quality of life and reduced health system costs, this is disappointing. Now, how does this happen? Here is an example case described in the 2015 annual report of the Auditor General of Ontario. I'm not going to read this because this is like those closing notes that Chuck Lorre puts at the end of each episode of the Big Bang Theory that you never have time to read. Apparently, these are called vanity cards. Now, I understand that after this presentation, these slides are being posted, so you are welcome to have a closer look on the CAG website if you're interested. But basically, the story is about a 90-year-old client who was referred to CCAC, what home care in Ontario was called then, for physiotherapy and personal support. This was in September 2014. The assessment rated the person as having a high level of need, but was not approved for physiotherapy and only 16 hours of personal support per month. The legislation, by the way, allows for up to 90 hours per month. In December 2014, the client fell and sustained a fracture. So perhaps that could have been prevented had the person received physiotherapy at an earlier time. At that point, the family requested additional personal support, which was not approved because of a wait list, and physiotherapy, which was also not approved. This brings me to the case of Ontario's aging at home strategy, which was a $1.1 billion investment over 4 years to support older adults to stay in their own homes. Doctors Kerry Koleski and Ali Peckham and their colleagues at U of T have done some really excellent analyses of the aging at home strategy. In this paper by Dr. Koleski and colleagues in Healthcare Quarterly, they describe how aging at home funds were redirected to acute care hospitals to address alternate level of care patients. So aging at home actually morphed into not aging in hospital. And they concluded that the care continues to be driven by the needs of the system and not its users. In this paper, which came out in Healthcare Policy, Dr. Peckham and colleagues provide some additional insight on how preventive supports for aging populations were appropriated by the more dominant actors in the system, which are the hospitals. And the power imbalance between the well-organized mainstream sectors and the more fragmented marginal community sectors meant that the resources ended up being allocated to hospitals instead of the community care. For a third case, we could look quickly at the UK, which had a similar experience. Candace Imeson and her colleagues at the Nuffield Trust looked at efforts to shift the balance of care to the community over many years. Their conclusion, multiple policy interventions, little shift. And I thought this article by a UK health administrator in the British Journal of General Practice might help to shed some light on this. They had like shifting care from hospitals to community. Now that's a role for hospitals. That brings us to myth number 2, which is that despite much good intentions, we have not achieved an integrated patient-centered healthcare system. As an example of this, our healthcare system often doesn't do too well in sharing health information between sectors. Here is a map with data from the Commonwealth Fund, which shows the percentage of primary care physicians who usually communicate with home-based nursing care about patients' needs and services. We see that Saskatchewan and New Brunswick physicians do a bit better, but the percentage is quite low in most provinces, with an overall Canadian average of 24%, which is lower than the Commonwealth comparison average. We often think of primary care as a gatekeeper and as the focal point of our healthcare system for care coordination, but the resources and systems are often not in place to facilitate that. Recently, I spoke with a leading primary care physician in the Waterloo region who told me that it was a big leap forward when the home care program started to send primary care physicians a list of the names of their patients who were receiving home care. Nothing about the person's service needs or care plans, mind you, but at least the physicians knew who was getting home care. We're also aware that we have a very complex healthcare system, which can be challenging for patients to navigate. American geriatrician Eric Coleman called attention to this in a classic 2003 paper called Falling Through the Cracks, which described how complex patients are vulnerable at points of transition and that practice settings often operate as silos. Our group wanted to study the processes of care transitions for complex older patients in a Canadian context and conducted an ethnographic study of care transitions for older persons who had experienced a hip fracture. This study, which we called the Info Rehab Transitions Study, had various modes of data collection, including 171 interviews with patients, family caregivers, and healthcare providers in 3 Canadian communities of different sizes. We followed these patients through all of their post-surgical transitions for approximately 1 year of follow-up, with patients experiencing between 1 and 4 care transitions over that time. I'd like to note that most studies of care transitions focus on only one transition, particularly the transition from hospital to home, but an older person with complex health issues might have many care transitions, including to rehab, to their own home with or without home care, or to long-term care. We have reported on this study in a dozen or so publications, but we tried to sum it all up in this 2019 paper in JAMDA, where we described 8 themes relating to the post-acute care transitions for older patients with hip fracture. I'm not going to go into all of these, but I'd like to give a few highlights from our results. We found that many patients often felt uninvolved, unprepared, and disengaged, as was illustrated in this quote. They gave me a slip yesterday saying, "You're going to be discharged on such and so date. That's it, you know, the hell with you, whether you want to or not, or whether you feel you're okay." This paper, led by Dr. Beth Hicks, describes a single case of an older patient's transitional care from hospital to home after hip fracture. The paper describes an older woman who thought of herself as strong-willed and independent-minded, but was given options that were largely illusory, with the patient's choices discounted for being unrealistic. So the system was happy to think of itself as patient-centered as long as the patient chose the options that were on offer. It chose some other option that was being unrealistic. Doctors Joni Sims-Gould and Carrie Byrne and their colleagues chose to take a strengths-based approach to see what post-hip fracture care transitions looked like when they went well. And the paper provides some positive examples. But to me, these don't necessarily provide encouraging illustrations of the system working well. They illustrated that when things went well, it was because healthcare providers were going above and beyond what was expected and using their own strategies for information and gathering and communication with other providers or care settings. Information systems and information sharing were often problematic. Electronic systems didn't seem to always work too well. Here's a rehab provider saying often when they send a rehab referral over, they send it very skimpy, thinking we'll pick up all the information on the computer. Sometimes we can, sometimes we can't. Systems did not always support sharing information with the next care provider, and we found, interestingly, that healthcare providers shared information that they assumed was what the next provider needed without actually confirming that with the provider they were sending the information to. This made me think of my toothbrush holder and my toothbrush. It's always been a bit of a mystery to me why the people who make the toothbrush holders and the people who make the toothbrushes never get together to compare notes, but I digress. The third myth I'll talk about is that health information technology is the future. And maybe it is, but I think it's a ways off. Let's start by looking at the past again. The fax machine was invented by the Xerox Corporation in 1966. Here's an older model hooked up to a rotary dial phone. This was 55 years ago. What about now? In the Info Rehab study, we found that the fax machine is alive and well and living in healthcare, as these two quotes illustrate. We need anything, we call over there and they will fax us whatever we need. Imagine that. They're not on the computer system yet. We'll fax through the pre-discharge form to the receiving unit. There is a lot of faxing that goes on. We found that information systems were often duplicated with both computer and paper records being used. A physician here says you should be moving to one or stick to the other. And patients often have the experience of getting duplicate assessments, as illustrated in the second quote, which says something about a possible lack of trust between providers and a lack of confidence in the health in the information system. So someone admitted with an assessment, the person receiving that patient would go in and do the assessment all over again. And that's a common story. Here's another figure from the Commonwealth Fund survey showing that Canada is an international laggard in the use of electronic systems to share information. This figure shows that Canadian physicians were much less likely than other OECD countries to electronically share patient data, lab results, or medication information. I'm going to now talk about some of the work that our group did as part of the Age Well Aging and Technology Network, in which we undertook a number of studies to understand what helped or hindered the innovation and adoption of aging-related technologies. And among other things, our work included a scoping review, a multiple case study, and many key informant interviews. Here are papers led by Dr. Maggie McNeil and also by Melissa Cook and colleagues. Our group was trying to understand the health technology innovation pathway, and we made some observations about the challenges of the Canadian policy context, the importance of partnerships, a lack of resources, and the need for user or consumer engagement throughout all stages of the process. Some of the things we heard, especially about the challenges of innovation in community-based care, you can see here. In home and community care, you're in the messiest space of all for technology adoption. This sector is significantly underfunded, significantly under-resourced, massively complicated, just a nightmare to organize. Another informant talked about we call the tyranny of the acute. It's extremely hard for those procurement agencies to think about adoption in the home and community care sector because the tyranny of the acute prevails. So the highest cost expenditures are still the hips and knees. The most influential interests are still the acute care hospitals. And this quote is certainly consistent with the work that Kaliski and Peckham did on Ontario's aging at home strategy. We also heard a lot about procurement challenges. And this, the message here basically is even if you're in a community care agency and you identify a technology that you can think is innovative and will make a great difference for your clients, it is almost certain that you will not be able to buy that technology. So provincial procurement regulations say that if you want to buy anything over $25,000, you need to get 3 quotes. Anything over $100,000, you need a fully public RFP. And in many cases, the agency wouldn't know exactly what they wanted. They might have wanted an innovator to come in and help them problem solve and figure out a solution that would work in that context. That's not the way the system works. There are rules about how we interact with industry when it comes to trying to be creative and doing things that are innovative and outside the box. Those kinds of rules are really going to bog you down. Another challenge is that costs and savings might occur in different sectors. So take an example of a technology that a home care agency might employ to detect risk for falls or to prevent falls. So home care clients are less likely to fall, falls are prevented. But where the money is saved is in the emergency room because that's where they're not going. So home care spends the money, emergency rooms reap the savings. So not exactly, so disincentive for one sector to innovate. So as I was putting this together, it occurred to me that much of what I've talked about has been discouraging. So I want to finish up on a more positive note, which is that the reality is that research and advocacy are making a difference. We now have a much better understanding of frailty, and we have methods and guidelines for early identification and management of frailty, such as these from BC. We know that frailty can be prevented, and the Canadian Frailty Network is showing us how with their Avoid Frailty campaign. A number of recent studies, such as these out of Dalhousie, there's Ken Rocket again, have shown that frailty status can be improved with appropriate multidisciplinary care. The CARES model in that first paper on the left is based on a goal-oriented multidisciplinary primary care plan, which combines a comprehensive geriatric assessment with health coaching. And also prevented through interventions such as exercise, as reported in the paper on the right by Perez, Zapata, and colleagues. We now have local and regional dementia strategies. Our group was involved in the development of a dementia strategy for Southwest Ontario. And after a lot of advocacy across the country, we now celebrate the fact that we have a dementia strategy for Canada. There is now a widespread realization of the importance and benefits of engaging older adults and their families in decision-making and research. It doesn't always happen to the extent that we would like it to, but it's certainly much more widely recognized as a priority. The pandemic also raised considerable awareness of the need for new national standards for long-term care, such as this process led by Dr. Alex Michailidis, and this process led by Dr. Samir Sinha. And there is creative work going on that is pointing to new approaches to home and community care. And I would encourage you to follow the work that Drs. Justine Giosa and Margaret Sari and her colleagues are doing at the SC Research Center. This group is building a model that would be an alternative to residential long-term care that would provide what they are calling life care on a long-term basis in the person's home. So packages of home and community-based care services would be provided based on the variable needs of community dwelling older adults. And we have the good fortune, at least for now, of having two aging-focused networks of centers of excellence in Canada, the Age Well Network on Technology and Aging that I've mentioned, as well as the Canadian Frailty Network that is doing outstanding work on the prevention and management of frailty in older Canadians. And last but not least, we have our own Canadian Association on Gerontology, which is working to close the research practice gap. I look forward to seeing many of you this fall in Regina, which will bring me back to Saskatchewan, where this journey all began for me. Thank you.
Thank you very much, Dr. Stolee, for that journey that you took us on today. That was fascinating. So we do have some time for questions and comments. Please take a look at the chat function should be at the bottom of your screen. And you're welcome to write in any questions or comments for Dr. Stolee. I'm not sure, Anthony, if we're letting people use their microphones in this presentation. I should have checked on that earlier.
I think he was hoping you would read the questions.
I will just moderate. Okay. Sometimes we do and sometimes we don't. So the chat function should be at the bottom of your screen there. So you're welcome to bring up any questions or comments for Dr. Stolee there.
And I'm assuming that I've stopped sharing my screen.
Yes. Yeah, you did. So we can see you a little bit better now in this view. Okay. Okay, so there's some questions coming in now. So let's see. Certainly some thanks for your excellent presentation. So Sandy asks a very provocative question. Would you say that there is ageism in healthcare?
Oh, that is a very significant question. I fear that my answer to that is yes. I think that the pandemic was a very unfortunate illustration of that. When the pandemic began, our system responded by rushing to shore up acute care hospitals. They discharged people from hospital to long-term care homes if they could do so, if at all possible, but did very little to protect those more vulnerable older adults who are living in long-term care, or in fact, who are receiving home care. So I think that was a clear message of that. In Ontario, after the first wave, which was a disaster, we had Premier Doug Ford saying he was going to put an iron ring on long-term care and things were going to be different. The second wave had more deaths in long-term care in Ontario. So I don't think in another sector we would have allowed for that. So I think, yeah, that's probably unfortunately the case, and something that I think we all have to try to overcome in order to make the care better for older persons.
Mm-hmm. Okay, great. Thank you. Okay, Trish asked the question, given the lack of funding and lack of sharing of health information, which you emphasized in your presentation, especially information outside of the acute healthcare system in Canada. So her question is really around, is this why there's no real centralized e-chart or e-medical record system in Canada? And do you see that something changing in terms of that regard?
I was trying to end on a positive note with my talk.
Yes.
I think, well, there is unlikely to be a one record system for Canada because we have, 10 provincial and 3 territorial healthcare systems, as well as many regional systems and then institutional based systems. And so trying to get all to agree on the format and the technology for that is very challenging. I think, I would acknowledge the efforts of my colleague, Dr. John Hurdes at the University of Waterloo, who has done a lot to promote the use of standardized assessment systems so that many parts of the health system use similar data collection and tools so to allow a common language. But that's not in every sector, and that information is not always used or shared as well as it might be.
Mm-hmm. Right. Okay. Thank you. Yeah, lots of issues around information and knowledge sharing for sure. Okay. Jody asked the question. You gave us lots of great kind of historical information and looking at trends over time. So she's asking, are yesterday's indicators, especially some of the data that you shared about hospitals, Are those trends still remaining today? And, what can we learn from some of those trends we're seeing, especially from acute care data?
So I'm not quite sure what trends you're
Well, she
referring
says,
to.
are yesterday's indicators, particularly in hospitals, still valid today? So she didn't specify a certain trend.
Yeah, so I'm not exactly sure the intent there, but I think my answer might be informed by the work that I talked about around Ontario's aging at home strategy. Uh, we will talk about shifting care from hospital to the community, but at the end of the day, the lion always wins, and the acute care sector seems to win out. But I think it seems to win out at its own expense. So we have a system in which home care is designed to take people from hospital so that they can be discharged from hospital more quickly. And that seems to serve the interests of acute care, but changes the workload in home care. We don't have a system in which home care is designed to maintain people in their own homes and to prevent admission to hospital in the first place. So we've set up home care at the bottom of the cliff rather than somewhere farther up the hill where it could serve a more preventive function.
She clarified here, she's asking about length of stay indicators and ALC. So people who are in hospitals who are medically discharged but have nowhere to go.
Yeah, I think they're, ALC is an indicator of a system in dysfunction. Older persons with complex health conditions come to hospital, and often what happens is they get their main issue treated, but they become deconditioned. They may acquire other health conditions or infections, and they end up staying in hospital longer than they really needed to. But then the hospital decide, well, you don't really belong here. We're going to call you ALC. We're going to put you in another category. So you shouldn't really be here, we'll say. So, and we'll kind of take sort of care of you until you can be discharged elsewhere. So maybe a different approach to acute care, better, early identification and management of people with delirium and dementia so that they get the appropriate care, making sure people ambulate quickly. In many cases, ALC could be avoided. But we are, you mentioned length of stay as well. We're kind of fixated on that as an indicator, as my friend Ken Rockwood says. Length of stay is not an outcome, it's an input. And we need to think about that differently and not design our system so that we minimize length of stay to make acute care look good, but at the same time result in dislocations in the home and community care sector.
Mm-hmm. Yeah, big impacts on our whole health system for sure, those issues. Question here from Gloria Gutman. So her comment is around gatekeepers within health authorities, and there seems to be some challenges there. So her question is around how can OT or PT, occupational or physical therapy referrals, how can we do a better job of implementing that within our health system?
My first answer would be, I wish I knew.
Mm.
My second answer, I think, might be that we need to look at maybe different ways of coordinating our community care. I think the work that Drs. Diosa and Sari are doing at SC Research is trying to propose kind of a new model of community-based care, which is organized around the actual needs of the person. So it serves the person rather than the system. And the coordination of that, if that could be centered more in the person's home, and our group has been kind of thinking about how do you make the home the actual hub of care coordination, and rather than maybe home care case coordinators or primary care physicians who aren't always able to do that. That might make some headway there, but it might mean maybe different people taking different roles.
Yeah, great. We still have a few minutes. There's some really nice comments there. I don't think there's specifically questions, but nice comments there about some of your comments about the fax machine that is still heavily in use.
Yeah, and that work was done a few years ago, but when I've kind of shared those results more recently, I often ask, so anybody, you healthcare workers in the audience, still using the fax machine, and hands are still going up in large numbers. So, I think we're certainly a ways away from taking advantage of the technology that now exists to share information in a more effective way.
Yeah, I in my work in assisted living, it's fascinating to me that it's still very, very utilized, not because we want to, but because systems we interact with require that we send things by fax. I was told it's security. That's kind of the issue around that. That's what I've been told.
I've heard that too. I don't really believe that. I've worked in settings where there's a fax machine and there's a fax lying on the floor that somebody forgot to pick up, or there's something sitting in the machine that's not gone to where it's supposed to be, and other people can look at it who really shouldn't be. So I think it's a long way from being as secure as we might like to be. And then it results in a paper copy, which gets carried around, gets lost, gets left on the bus, whatever.
Exactly. There's a lot of issues around the security, and there's so many other ways we do security and with other kinds of systems online. So yeah, that one is kind of fascinating to me, for sure. Let's see. We just still have a few minutes. Anthony said that he can unmute people if anyone would like to use their microphone. At the bottom of your screen on the reactions button, there's a raise hand function. So if you want to speak, please feel free just to raise your hand and we can make sure that you get unmuted. There was another comment to Dr. Stolee about kind of a human resource issue where we have many people who the note says about nurses or healthcare workers who aren't wanting to work in the acute care system any longer, various kind of issues of working in that environment, and would really prefer working in other settings outside of acute care, especially like you talked about care homes that are not so institutionalized, but in other kinds of settings. So yeah, she mentions, this is from Trish, mentions, different models of different ways of using our healthcare resources to spend in different ways. Like you showed so many, models where in the past and present, we're spending so much on acute care.
Yeah, I think there are better models out there. I see in the chat she's mentioning a neighborhood care model, and I know Veronique Boskart in Waterloo, who's our association president, has done a lot of work around a neighborhood concept for long-term care. So I think that our physical design and funding models for long-term care homes often make them unattractive places for older people to live, but also unattractive places for people to work under those systems. So many are calling for what I think the questioner is suggesting, a more neighborhood model, more home-like long-term care models, like the greenhouse model is another example. But we don't have maybe the designs, the models, the funding systems in place to support that. And we're also causing dislocations by fixing a staffing problem in one sector at the expense of another. So in Ontario, they're promising to increase the staffing levels for long-term care. Again, sometime after the next election, we'll get to that, but they're going to increase that. But we already have an issue of staff shortages in home care settings. So we're going to likely rob the home care setting of personal support workers who get paid more in long-term care homes and paid still more in acute care. So the system doesn't make that an equal playing field. So I think we need to do a lot better with our human resource policies and plannings and give workers an appropriate wage and job support wherever they're working, home, community, hospital, long-term care.
Yeah, that's an important point. I mean, working conditions and remuneration and benefits, irregardless of the setting, right?
Yeah, and I think again, the first question was about ageism. I don't, I think the way, many of the persons who are working in home care and long-term care are themselves sort of marginalized persons who come from low socioeconomic backgrounds, or they're recent immigrants, or English is not their first language. And in a sense, we take advantage of that by, giving them sort of low wage positions when they don't have a lot of other options. But that, that's not the way the system should work. And I don't think that would fly in many other sectors.
Right, thank you. Okay. All right. Any other further comments or questions or anything else you'd like to add, Dr. Stolee?
No, I've really appreciated the questions. I think it's, and we could go on at some length on many of these issues. I've been very grateful to have the opportunity to share some of our work and some of our thoughts on some of the issues facing us. But I think, I sometimes joke, 40 years ago when I started in this business, everybody said, geriatrics, that's the coming thing. 40 years later, we're still saying that, which is, unfortunately, maybe our time hasn't come yet, but it will come. And I think, I'm hoping that we'll all continue to be encouraged to continue to do work for the betterment of older adults in our communities.
Great, thank you. Thank you so much. There's certainly lots left to do, lots of challenges. So thank you so much for that journey you've taken us on today, and your perspective and your wisdom and all the knowledge that you've been able to share with us about the myths and realities of aging and healthcare systems for older people in Canada. So thank you so much for this, and thank you all for joining us today. And the recording will be made on the CAG website. So thank you all very much and have a wonderful day.
Thank you.